Welcome back to the pIBD Digest, where guts are small but the conversations are mighty. I'm your host, Dr. Tracy Coelho, and I'm joined once again by my esteemed and ever-curious co-host, the one and only Dr. Chris Bakewell.
Hi, Tracy. Welcome back, everyone. I see that you snuck in a new slogan there, small guts and mighty conversations. I was just thinking that my gut maybe isn't so small, but you're probably referring to our patients more than us. So on today's podcast, we're continuing our overseas tour and not satisfied with our hideous 35-degree heat here in the UK. We're racking up some more air miles and we're going to head somewhere, if you can believe it, even hotter.
That's correct. Today we are heading straight to the UAE. We will be on a virtual safari today with a very special friend of mine.
It's not an area, to be fair, that I typically associate with pediatric IBD, but I'm looking forward to being enlightened and having all of my ignorances challenged. And I think, to be fair, we're going to learn a lot about their healthcare setup.
We will definitely learn about their healthcare setup. And our special guest today is arriving in style on a gold-plated camel, obviously. So, dear listeners, buckle up. This is not a mirage. It is the pIBD Digest Dubai Safari. And we are about to ride straight into the GI desert. We are diving deep into how pediatric IBD care is evolving in the UAE. And our guest, an absolute legend.
I think we're all looking forward to which music you choose next, Tracy, for the introduction. I'm eager to hear.
Well, our guest is the David Attenborough of Emirati Gastroenterology. Not just that, he's a die-hard Greek. So basically, the Greek Lawrence of Arabia with years of experience in the UK health system. How cool is that?
Yeah, I didn't know such a person existed, a cross between David Attenborough and Lawrence of Arabia.
Well, Chris, the gold-plated camel is circling outside our virtual caravan. Should we usher in our guest, our legendary guest, riding on this camel?
Yeah, let's go for it.
Towering high like the Burj Khalifa, shining bright as the GI Helios, here he comes, draped in his dazzling tunic of intellectual gloss. Warm, chatty, truly so humble, yet brimming so bright like a true GI boss. So ladies and gentlemen, without any further moment's loss, please welcome my clever friend, Dr. Christos Tzivinikos. Carlos ήρθες φίλε μου.
Καλώς σας βρήκα.
Don't know what to say to that.
Thank you very much, Tracy and Chris, for this opportunity and for the invitation for this very nice podcast. With Tracy, we've been together as SHOs probably 20 years ago, not to disclose our age, back in King's College Hospital, almost 20 years ago. And it's a great pleasure to be invited and share my experience in the Emirates over the last 7 years.
Well, welcome, Christos, to the Paediatric IBD Digest podcast. I'm currently working in King's, so it feels like a very King-centric start. So, it's nice to all have some commonality.
Indeed, very King-centric. Now, as a brief introduction to our listeners, Dr. Tzivinikos is a consultant pediatric gastroenterologist at the Jalila Children's Specialty Hospital, Dubai, and a clinical associate professor at the MBRU School of Medicine, Dubai. A quick shout out to my dear friend Christos, an incredible colleague back in our junior doctor days at the King's College London, and I actually owe him big time. This is because the day before our gastro grid interview, he called and said, "Get to London tonight, snow is coming." And sure enough, the next day, transport was a disaster. I made it thanks to Christos, and honestly, part of my career is your fault.
I think you've been exaggerating, Tracy, but I recall all that and the good times together. And here we are, fast forward, both consultants in pediatric gastroenterology. I mean, the journey here had been a bit of roller coaster. I came a little bit to the unknown, but the challenge was that I had to set up a unit from scratch. And that was actually the main challenge, which I took. I was happy at the age in this hospital, generally the NHS. I'm grateful to be neutral there, trained there in the UK system. LDH in this hospital is a great hospital, and I still miss it from time to time. But sometimes you have to take some opportunities which come in life. I was not looking to go there. They just found me on the LinkedIn. They saw me in a brand new hospital. It was pretty much empty. 200-bed hospital had only 20, 30 beds at that time, back in 2017. So there was a colleague from the US who started together, at least for the first 1.5 years. Then for family reasons, he left. And he had the interest in motility. I was more nominal, IBD, endoscopy. So we teamed together and we started looking on the unit. Very soon he went to the medical director position. So I was pretty much, alone to set up everything from scratch. All I found was 0 patients and only 4 scopes to be around because the hospitals had just had open, okay? So, being an IBD, I will say, this is my special interest. The first 6 months, I didn't have not even a single IBD patient. And I say, what is happening here? I mean, why they don't exist? How come? And now I don't want any more. Maybe I have more than 200, for my own, because this is the way it is, brand new hospital, people that they get know to you. It just takes time to build up, It's not like the NHS, you have these huge waiting lists. So you start something from scratch. So now just to explain a little bit what's happening in the Emirates, there are 2 systems. There are the local patients, the national UAE families who actually enjoy NHS-like care. Everything is free. Mm-hmm. No, no restrictions, no hurdles there. They get whatever they need. And actually, I have to say, without waiting lists. So they are very, they're very lucky on that. And then the majority of the country, 9 million, they are expats. The vast majority, actually. And there is a US system, okay? So there is an insurance-based system. So you deal with 2 different patients. And there are also patients who don't have insurance, okay? You have to work on, rely on charities. Or I have to say that, and I feel this many times, that you have to feel that you live in a country with low resources. Because the resources are there, but are not accessible to these patients. But having said that, there are charities. There's no an IBD charity like TICRA, for example, in the UK. But there are charities who cannot help everybody. And at least my hospital, because the only children's hospital in the country, it does help a lot, for example, for admissions for acute severe colitis, if we're talking for IBD. At least things are done there. And not much questions asked in a sense, okay, there is a bill afterwards, but there is a lot of, support from the management. The same happens, for example, for dialysis patients, complex cardiac operations, transplant, liver and kidney. So these life-threatening, conditions, they've been supported by the hospital, and we're very grateful for that, to have it, because we are the only children's hospital, and the leaders of this country, they made it in this way in order to serve the wider community. But not everybody can be covered, okay? We have to be honest with that.
Thanks very much for that, Christos. That was an excellent summary of your journey so far and what you do at the moment, and definitely the reasons why we've asked you to come on the podcast today. We're fascinated by what you do, and we'd love to pick through that. I will just pick you up. You've skirted over the fact that you introduced or you facilitated Dr. Coelho for getting a job in gastroenterology. So you do have to bear some responsibility for his presence in the gastroenterology community. So I apologize to everyone for your role in that. But if you'll indulge us, I think, it is a really interesting pathway to go from the NHS system. You trained in London, as you said. I think you're saying that you took on quite a senior responsibility in Alderhay Children's Hospital in the gastroenterology team before moving out to the UAE. Would you just take us through that pathway and kind of how it unfolded a bit more for you? And what was it about going to the UAE that excited you and what you felt you could do out there?
Thank you, Chris. As I said, the main challenge was to set up something new from the beginning. In your medical career, I think very few times you have, unless you open your own private practice, just stand alone, very few times you have, opportunity to set up something from scratch. Usually someone is before you, establish hospital, establish department, pathways, patient load, everything. But that was brand new. And the other, I was quite lucky. This was a government hospital. Okay, so because this is the other big, split in the UE medical world. There is a private sector, there is a government sector, and that I'm very lucky to be in the government sector because in the government sector, there is so much focus on revenue, on patients. They still review that, but they don't put obstacles to quality. For example, more or less, I managed to copy whatever I had in Alderhay there. For example, talking radiology, MDT, MDT with the surgeons, MDT histopathology. This will not exist in there. And, they do exist in the private sector as well. I have done, some collaborations with private sector, adult GI unit. And now the government hospital as well, we do pIBD transition clinic. But, there was no, okay, you need this time, for grand round, for MDT, why not to have a clinic and see more patients? So that was very lucky on that. So, yes, I had patients on insurance. So that was the biggest difference for me. Very annoying because I work only in government, funded systems back in Greece and in the UK for 13 years. So I never experienced this, insurance, insurance issues to claim for infliximab, to claim for endoscopy, to claim all that. I have to say the majority of people, they get what they need with a lot of back and forth emails. I use the ESPAGAN guidance as usually my argument for the insurances. But some people, I would say 20%, they will not get what they need. And then I have to find other avenues to cover them. That was one of the biggest challenges for me because I never experienced before. NHS, the care you need, you have it. You don't have to go through claims. You don't have to go through that. And thanks God I had the local patients. I didn't have to worry about that. Now, the other challenge I had, you have usually a CHO, you have a registrar. There was no such a thing there. You are 24/7 on call, and they ask you for anything. We had a US system, which is called hospitalist. As the hospital was growing, eventually, the hospitalists, they are like, maybe you used to have the staff grade doctors that used to be on the ward in the past, Tracy. So these are people who do only hospital pediatrics. It's actually a fellowship in the US, and they are very good, I have to say. So my role was mainly consulting one. So the most responsible physician, the MRP, so it's called there, was actually the hospitalist the first few years. Still, I was responsible for the admissions, but they were dealing with things. So we just have to call you and consult. That was especially what I saw there was a lot of foreign body ingestion. So they will be called almost every 2-3 nights to get in the middle of the night to remove foreign bodies. The other thing I had to pick up was hepatology. There's no hepatologist there. So I have to pick up with bleeders, banding, all that. We did it, in Leeds. But of course, it was something you had to pick up because these patients will come. This is only children's hospital, and they knew that they would be covered there, even if they don't have insurance because the hospital is supporting. So they were ending up on your door. You have to deal with them, So that was an interesting now, addition in my skills. I have to uplift my skills a lot on that.
Christos, you're giving me palpitations. listening to it. It sounds like a daunting prospect, and probably, to be fair, in the modern times, not something that many people would have done, go to a brand new hospital and set up a service. Certainly not in a fairly developed place like the UAE. Is there anything you can crystallize down, having done that process, for someone else that wanted to go out and do that, or someone that was in a similar position? What did you learn from that? And is there anything that you think, God, I wish I knew that now years down the line?
The thing, I didn't know exactly what will happen, but even in my case, so you just go along. But I have to say, I was lucky. I did not have resistance from the management to, to set up things, to buy what I need, the scopes. My colleague, for example, who was with me the first 1-2 years, motility equipment, everything done. Thanks to him, I pick up a little bit of motility as well, but I give it now to some other colleagues who have a big team now. That was, UAE offers a lot of, resources. It's a modern country. If you think about this, it's only 50 years old. Okay, 1971 was established. It's a fast-pacing one, especially Dubai is a big metropolis. Keep expanding. We have a lot of spaces now. Imagine now the population has gone up 800,000 estimated the last 4 years after the pandemic. So it's all increasing the population, everything. There's a quick pace. AI is coming now. We are very lucky talking about IBD. We get usually after 1-2 months all the new biologics and small molecules because they follow FDA.
What about the gold-plated camels? Are they still around?
I haven't seen any gold-plated camels. Yes, but
these are Tracy's dreams about Dubai. I think when he thinks about, in those difficult night shifts or when he's on call, he thinks about going out there for the gold-plated camels.
Well, fantasy about gold-plated camels, air-conditioned suites in skyscrapers, Rolex watches. I suppose it's good to have a coping mechanism, especially on a bad day. Anyway, I'll let you carry on.
They follow the FDA from the US. So once FDA is approved, they don't wait for EMA. Usually they follow on. And I have to say the insurances, they don't look much on the pediatric label, which is very fortunate. As you know, have this big problem in IBD world globally, especially in Europe. It's been 10 years now since the ustekinumab vedolizumab has been licensed for adults, and still there's no pediatric label. This is a big problem now. And the Esfagan Porto group has written recently to FDA and EMA, and published a paper by Professor Dan Sender that we need. So it seems that they don't have this issue. As soon as the cost is covered, it's okay. Now, so I cannot say any, because as we say back home, if you go to this dance, you have to dance. Of course, you can quit. Okay, you can quit. It was difficult to be, 24/7 on call. Calling you all the time for everything. With medicine becoming, as you know, everywhere more defensive. Even the other colleagues always ask your opinion for everything. WhatsApp is something which works very, very a lot there. There's no letters to the GP. There's also, of course, EPR. Everything's electronic. There's no paper notes. We still had some paper notes when I left UK 2018, but I think now it's gone all electronic. So everything is recorded. There's something I experienced myself, and I had to go through. I don't have, I would say, if anything, an advice is patience. I didn't know anybody there to ask for what is happening. I knew a colleague in Abu Dhabi from some conferences, but it was a different city, different, completely system. However, he couldn't tell me much. It was a brand new hospital. He told me it's a government hospital. It looks to be the only children's hospital in UAE, specialty base. So go for it. That's all I knew.
No, I think, that was a really nice summary, and it sounds, it sounds like you've been through a very thorough process, I suppose, of setting up this service, and probably the initial investment of time and energy that you put in has now paid dividends, and the systems in place probably a bit more fleshed out, that you're able to deliver a service without being completely at the beck and call of the hospital, hopefully. Well, we know that you're in Greece at the moment, so you've at least managed to take a little bit of time away from from the Arab Peninsula. But I was going to ask a question. You've kind of touched on it already, and I think that's really helpful. But in terms of the perception of the UAE and Dubai in general, obviously we see the bright lights in this very resource, an area with a lot of resources. Are there health inequalities in the UAE and Dubai? Are there people that don't manage to get the care they need? Or largely speaking, it sounds like from what you're saying, there's a very good public health service and most people would get the care that they need and maybe even, what sounds like a very good standard of care. Certainly speaking specifically for gastroenterology.
As I told you, there are various categories of patients. The local patients, they get everything. It's NHS care, and actually it's based on the NHS system. In order to be referred in our hospital, especially now the last 2 years, you have to go to GP, get referral, and then like in NHS, you just screen the referrals and you triage them for the locals. Or even an expert now is required to go to GP to get to our hospital because we're a government sector. The private sector, you just pick up the phone, call, and this was the case actually the first 5 years in my hospital. There's just one parent, and sometimes this was a bit, awkward because they're coming for irrelevant reason or something very trivial. But now have clear pathways for constipation, for example, common things, when to refer to us, an IBD patient to be the prioritized. And then there are the experts, which are the majority of the patients in UAE. This is a country of 9 million experts, 10 million population. We have insurance-based, but most people, they have a work, okay? So the insurance comes on, and usually, the insurance covers the majority of the care. But there's 20-30%, the insurance either is not enough, or low-paid workers, where they have no insurance, zero, and then it's your job to find charities. Companies have adapted to that. For example, for adalimumab, there's a good support system where even if the patient doesn't have anything, there is some charity where it's called, I don't want to say the name now, but there is some support programs for the patients where they actually, they chip in and they give the majority of the money. And that is for adalimumab there and infliximab, because they're only pediatric label. Unfortunately, not available for the rest because they don't have pediatric label. They have this rule, they can make a basic support program. Is funded partially by the charity and the company, but only for the pediatric label biologics, which at the moment, unfortunately, 2025, as you know, remains only infliximab and adalimumab. And so there are patients who cannot get access, but our hospital management is quite helpful. We try to help as many as possible.
Yeah, and it sounds like over time you found the IBD patients that maybe weren't as obvious when you first started. My understanding, and this may be wrong, but this is my understanding, is that there has been a steady increase in IBD cases within pediatrics in the UAE over time, sort of maybe not to the extent that the UK or Canada or some of these other places have seen, but certainly following that upward trajectory that many of the developing nations are seeing. Is that so?
Unfortunately, yes, because they have westernized fully the diet. I keep saying that McDonald's, KFC is in every corner, and a lot of fast food. And the Arab population, generally speaking, they're not predisposed genetically for IBD, like the Caucasian or other populations, but because they get westernized diet, westernized lifestyle, I think, admittedly, from all the epidemiological studies, this is the number one factor of epidemiological factor for increasing incidence of IBD, and this is also happening to this population. But we have a lot of experts. We have a lot of Europeans, American patients, Australian patients. We have 200 nationalities, in UAE. But even the local patients, they have much more than before. The Saudi colleagues have published some studies. We try to make a registry slowly. We're only 7 years old. We participate in the pIBD, set quality study by ESPGHAN. As you know, I'm very active in ESPGHAN for many years, and I have, endorsed. I have, engaged with all the guidelines and a lot of projects running with IBD from the Porto group. but we don't have a registry yet. But I can see that it's increasing. Every week we have one new patient IBD, sometimes two. And what I see for myself is we see younger and younger. I don't know if you see this in your practice. And we have this population with a VIBD, which is because of the consanguinity. Now, I put one of my fellows, and that was one of the landmarks, in this service development, that once we built up the unit, we became a lot of consultants. I'm very lucky to have another 2 UK consultants. Tracy knows Dr. Balaji Krishnamurthy. We've been together in LDK. He left before me in UAE. He came, Dr. Ajmal Kader. There are 3 UK consultants and 3 others from the locally trained. And now we have a 7th US trained. So we're a big team now. 2 years ago, I started the fellowship. And that was another, landmark in the service development. And I put on one of my fellows to look at how many VIBD patients we have less than 6 years of age. And we have about 70 the last 7 years. And imagine some of them, for a new unit, it's a lot, 70. Some of them, they move country, they go back. It's a moving population. We miss them, but 70 is quite a lot. And we have few monogenic diseases. We had 227A patients, trichohepatoenteric syndrome, visceral Aldridge. It's just a memory of my mind, where we had to to look on that. We are very lucky as well. I remember I arrived the same day with a very bright genomics, molecular geneticists who came from CHOP, Dr. Ahmad Abu Tayoun, and we have an in-house genomics center. So in 1 week, he can give you a VIBD panel. I don't think so many centers that have that. We recently had an Alagille syndrome patient who presented at 2.5 months of age with another center. And, Alagille with biliatresia, there's so much mimicking there. He gave you in 1 week, he does whole genome sequencing now. Yeah. So we're very lucky to have a genomic center as well.
So with regards to the westernization of the diet, now you are a die-hard Greek. So in your capacity as a Greek origin consultant in the UAE, do you ever recommend a Mediterranean diet in your hospital?
Of course, and this is, all of us, especially pediatric gastroenterologists, I think in our consultations, we have to put diet there, as a part of a consultation. I don't know if you have seen the paper from Naspagan, the culinary medicine approach we need to have. In the UK, we use exclusive nutrition for induction of remission in Crohn's for many years now. I look a lot at diet. Actually, the parents they are looking on diet. Mediterranean diet, as we know, with all the studies, if you look, it's the best diet you can have, even for prevention possibly of IBD, okay? Now, if you end up with Crohn's or IBD, then I introduced in March, in the spring of 2019, the Crohn's disease exclusion diet, because I saw the exclusion diet nutrition for a lot of patients who are not, complying. It took me a while to have a gastro dietitian. However, the dietitians they engaged, they all did the training for CDET, and there is a little bit of resistance on the nasogastric tube. I don't know, this is cultural. They don't like the nasogastric tube. I remember we had 98% the success rate on EEN in LDK and in Royal London, the places that I work, because we're putting on the consent, as you know, the initial endoscopy, you will wake up with a nasogastric tube, and then the success was big. This, they don't accept. That's another big problem I have with the gastrostomies to convince, but gastrostomy is definitely something more invasive, okay? But the nasogastric tube, so then I have to find another alternative, at least to get some diet on board. And I know there are a lot of debate about, there's only one pediatric RCT now for CDET diet and one adult, but still I think it's an option. And I use it mostly as a combination treatment. Diet is very important. We see the rate of obesity is increasing. And, I do the obesity clinic, I do the elastography, because I do the bowel ultrasound myself. And if you, as you know, this is an evolving new skill now for anyone who does IBD. I believe everyone who does IBD in the next 5 years should know also point of care bowel ultrasound. So got the Samsung machine, and now we run this clinic for a year. I got IBUS certification, as you know, the International Bowel Ultrasound Service. And this has helped me a lot on the assessment of these patients, even distinguishing these, referrals will get with a little bit of high protectin, query IBD, query IBS. It helps you distinguish. But for the reassessment, it's something I have, probably reduced the last 1 year, 25% of my reassessment colonoscopies, especially for escalation. You have the symptoms, you have the biomarkers, you have the bowel ultrasound. Why to put under general anesthesia, this patient? Especially, I'm a government sector. I don't have any incentives for revenue or more endoscopies.
One question about the genetics. Now, you mentioned about the high rate of consanguinity. Are there any specific monogenic IBD cases, any specific genes, or is it just generic?
As I told you, we had 2 to 7 patients. We still have one. The one unfortunately didn't make it through a line infection. This is a very, very, I would say, nasty phenotype. It's a stricture one. I tried the protocol by Alexio Muse from Sekils, leflunomide. He worked partially. It's long-term PN. Lot of dilatations for the small bowel strictures. It's something I never came across. We had the trichohepatoenderic syndrome, which you could say this is on the VIBD scale, viscous order syndrome. This is the ones I have come across. Some autoinflammatory, I haven't come across for the other known ones, like IBEX but I'm sure sooner or later will come up. This is the ones I have come across now.
Sure. You haven't had a patient who needed a stem cell transplant or for IBD?
This 87A patient, who is now 16, actually had stem cell transplant in the US in 2008-9.
I see.
But somehow it didn't work, and the disease came back, and he's on PN.
So you've sold us the service. You've got an incredible genetics turnaround time. You've got IBUS, so intestinal point of care ultrasound scanning. You've got what sounds like a fantastic diagnostic setup. And you've touched on when you talked at the start about the treatment of inflammatory bowel disease over where you are in Dubai. So what are your governing principles? I suppose you've said that you follow mostly ECHO or ESPGHAN guidance on the management, but you've alluded to the fact that you use the small molecules maybe a bit more readily, or maybe they're quite easily accessible to you. Is that fair to say? Maybe if you compare it with an NHS-based system.
Yeah, I had access to all the new medications. Talking about small molecules, I started using back in 2019, tofacitinib. And if you see, I ran a project for 4 years. It was difficult through the pandemic, through the Porto Group. There's a publication in IBD journal for tofacitinib with about 101 patients, with a lot of care by Oren Leder, my colleague in this project from Israel. And we published the retrospective experience. Now, the last 3 years, I use upadacitinib for refractory cases. Okay, we're not talking about start with this. Now I have access to all the biologics. Now, if you look and for the patients that they can afford, I know the currently pediatric studies still infliximab remains probably the first line biologics, but I look a lot on the adult literature, and I'm pretty sure you're aware of the EVOLVE study. It's a real world data, but with thousands of patients. It looks like if you have the choice to start with the new generation biologics, I'm talking about vedolizumab, ustekinumab, risankizumab, and now the new IL-13s, and or anti-TNF naive patients, you can have a better efficacy for them. And the good thing is that even if they fail, the infliximab and adalimumab works like a new as a second line. Vice versa does not happen. So I do this practice, which is not yet an established pediatric practice, but I follow the atlas for the patients I can. For the rest, I follow the ECHO ESPGHAN guidance and usually infliximab. I can say that, and I'm pretty sure this is your experience as well, we do much more top down like we used to do 10 years ago, much more early. And I think this is probably the right thing in the most of the cases, because we don't lose this opportunity, window of opportunity to, to get remission, quick remission to the disease, especially in a growing child who has to go through puberty and adolescence and everything. So yes, I'm very lucky. I have, even for the insurance patients, they don't much bother if the cost is covered. They don't mind. I don't have biosimilars as well. There's biosimilar for adalimumab, there's biosimilar for infliximab, there's biosimilar for ustekinumab now available. It's available, and the new thing now, which I'm planning to do, because we have a IV infusion unit now with a lot of patients on infusions. I know it's still not pediatric label, but I follow the adults at least for any patient above 40 kilos. My next plan is to switch patients after induction to subcutaneous infliximab. The studies have shown in adults much better steady trough levels, less immunogenicity, and the patient does not come in the hospital to lose a few hours.
So sounds like there is less red tape on the reserve drugs compared to the UK. Is that correct?
Right, yes.
And has it been long enough in your practice out there to get a handle on what your rates of surgery have how they've changed over time? Because of course, if you have access to these drugs and you're maybe, leading the way in some cases in using some of these, what we would consider second or third or fourth line treatments earlier on in therapy, do you get a sense that you're having reduced cases that need to go to pediatric surgeons, or perhaps in the years you've been doing it, you may not be able to get that overall view?
For sure, with the advent of biologics and now all the other medication, we have much less colectomies, much less ileocecal resections nowadays. For example, I see now there is a popcorn study looking on this Crohn's ileal resection, and Amitasa is running this for 5 years now, 6, because the centers don't have much resections there, cases to recruit. And I admire his patients, we have only 5-6 patients. At least for Crohn's. Colectomy, top of my mind, haven't tried everything I had, small molecules, even dual biologics, we have about 10 patients with dual biologics as well. 5 or 4, for a cohort of 350 IBD patients overall, definitely has reduced. And I'm pretty sure probably you see this in the UK as well. Looking back 2014, you remember, Tracy, it was on about 2013-14. We couldn't use adalimumab for UC. Remember, after infliximab, there was nothing afterwards. It was only colectomy.
So having trained in the UK and now in the UAE, how do you think the two systems compare, not just in resources, but in the mindset around chronic diseases?
Look, the NHS system, for me, and I don't exaggerate, as you know, I'm a little bit politician as well. It's the best system in the world. Insurance system is usually not fair for the patients and the families. There are restrictions. You have to fight for that. Families have to spend a lot of money, and and it's a very big school. And for me, it's an example for a lot of health systems to copy. Especially the organization has. I know the UK governments have not supported much the last 20-30 years, and they try to make it fail. But the heroes who still work, and I'm talking about the NHS workforce there, they still hold this strong, and it's a blueprint of a good care. Now the Emirati patients, they get all of that for free. And they are very lucky in the UAE. The others get the majority of this or part of this, and 30% they don't get that. Unfortunately, they don't have access to that. Don't have to find charities. We have to find medications from other countries, like I don't want to mention the names, just from the other non-developed countries, just because they are cheaper. Okay, as you know, the companies, they have this price policy. It depends which country the price is different. So this system of radiology, MDT, histology, MDT, MDT with the surgeons, MDT clinics. I mean, we're very lucky. We're the first ones we had this in our hospital. My other special interest is, in LDK, we had feeding clinics, neuro feeding clinic and cardiac feeding clinic. I do gastrostomies myself. So I have a special language pathologist, I have dietitian. Now, finally, I have an IBD nurse, gastro nurse for the parenteral nutrition program. And now I'm training here with my other colleagues on IBD. She's taking care of actually now the biologics patients. And the nice thing we had in Royal London with Jane Lindsay, the fantastic transition clinic there, and the weekly biologics, visual biologics was run, which I copied also in LDA and try to copy here as well. So all this come from NHS as a paradigm of care and organization. And I'm lucky I had the opportunity to establish these things. In a private hospital, I'm not sure if I had managed to do that because there are other priorities there for your time as a clinician. However, still, there are no private adult GI services which I collaborate. They do have some of the MDTs. And the one advice I will give for the colleagues who are in the UK, if you are in a hospital, okay, if you're standalone in this hospital, may be difficult. Talking about IBD now, if you are in a general hospital with adult GI service there, try to get in touch with your adult IBD colleagues. I have to say, I learned most of my IBD practice from the Royal London Hospital, where we had a fantastic, was like more or less like a one department, the adult and pediatric GI service. And even I went to the LDA, of course, with personal pursuing, and finding people. Every Friday, I was in Royal Liverpool Hospital having a joint IBD MDT with the adult IBD colleagues. That will helps a lot. And also, as you know, the adult colorectal surgeons, they are much better than the pediatric surgeons, when it comes in, pouches and stuff like this, this is definitely a place of adult colorectal surgeon. That's my feedback from all this journey so far.
Thanks, Christos. I think that's a really excellent point, and one that's come up, a fair few times on this podcast series. The idea of trying your best to manage yourself as one team, pediatric and adult, as opposed to seeing yourself as managing pediatric IBD, because of course it's the same condition. We are managing the same condition and the same patients. It's an arbitrary line that we stop at 18 or wherever you draw that line, maybe sometimes 16. So thanks for emphasizing that. And I think that that's really something that our listeners hopefully have heard before and will hear again on this series. I was just going to ask if it's okay, because one thing we haven't touched on, and we're probably coming towards the end of the episode now, is research where you are, because you've got so many fantastic resources, and it sounds like you're building up, a really impressive service. Do you include research as part of that, and do you have any particular topics where you think you'd like to explore over the next 5 to 10 years?
Yeah, thank you, Chris. Our hospital is only 8-9 years old. It still has a lot of work to do, but Dubai Health, which is now an umbrella organization with 4 hospitals, so we have the Children's Hospital and 3 other adult hospitals, they are together. It has put research now higher on the agenda. And finally, after a lot of pushing, we have a clinical trials unit in the hospital. The neurorehabilitation department moved to the old empty hospital now. So we have the space. Still, of course, we don't have so much of research nurses and data administrators. So you have to do this work on your own. As you can see, probably from publications, a lot of them, they are collaboration studies by Aspecan from the Porto Group or others. So you have to do this work, but hopefully soon will not be that. Now, I'm on PI on the phase 2 clinical trial for microvillus inclusion disease. So we run also clinical trial, and other colleagues as well, they run industry-based clinical trials. But still, we have a lot of way to go through. It's part of our job plan. We are lucky in the management. We have also UK trained consultants, other specialties. And we have this job plan. We try to mimic it, with the NHS. At least we have SPA time, and that includes research as well. And the last 7 months, I'm also part of the local ethics committee, the board. So I'm getting more experience to that now. it is something which is growing. Most of our research at the moment is on retrospective observational studies around this clinical trial now, as it stands now for the next few months. But with the opening of the clinical trials unit, hopefully we'll have more research, because as I say to the management, this is 200-bed hospital in this region, and we have so much potential now. They will have so much patient load, rare things I never saw in the UK, syndromes, fellowship programs, and it's time now to invest more in the research. But it's something still an ongoing process, I have to say.
Yeah, and I think with that kind of almost European mindset and UAE resources, it sounds like you should be able to do something, really interesting, and hopefully we'll see a lot coming out of that part of the world.
Yeah, one more question I wanted to ask. What does the training pathway for pediatric gastroenterology look like in the UAE? Is there a structured postgraduate route or fellowship programs in the UAE?
As I said, I started the fellowship program 2 years ago. We follow the Saudi Commission. Basically, it's most of the Saudi colleagues have been trained in the US in the 90s and 2000. I have to say they are very good, and they have the US system, and the rotation is a US based. And now have the first fellows coming at the end of the year. One of them will go to sick kids, the other one will go to sick kids again for some post fellowship. But there's also a colleague called Dr. Mohammed Baghdadi and his team. Also has 2 UK trained consultants there. Is running fellowship program over the last 6 years. This is a Khalifa Medical City Hospital. It's established for 25 years there in Abu Dhabi. It's a government sector again. So these are the 2 certified pathways if you want to train in the UAE. One in Al Jalila Children's Specialty Hospital, and the other one in the hospital in Abu Dhabi. So there is opportunity and then again it's 3 years, okay? It's 3 years.
To be fair, I think we've covered everything. Christos, you've been amazing. You've sort of, I don't know if it was deliberate, but you really nicely covered all the things that we were hoping to talk about. And I'd really like to thank you for spending the time on your holiday in wonderful Greece to meet us and share your wisdom from what sounds like a very challenging, rewarding process of setting up a brand new, spanking and very impressive children's gastroenterology service.
We still have a lot of work to do. We are still a new hospital. And as I said, NHS is a big school. And that was the blueprint. I was nurtured, and I tried to, with all the differences and the health inequalities, to get to the new hospital. And I was lucky enough, most of it, to apply it. It's a great pleasure to speak with Tracy and Chris for you. And thank you for the opportunity to invite me and be the host of your podcast.
Christos, thank you so much for your time. Bye for now and take care. Dear listeners, before we wrap up, it's time for something close to my heart, a poetic reflection. I'm sorry this one is a little longer than usual, but I hope it resonates. It's titled Towards the Oasis of Hope, inspired by the advances in IBD treatment and the resilience of those living with it. This piece is a small tribute to the progress, healing, and the brighter future that science now helps us see. Towards the Oasis of Hope. Gliding high in all joys that childhood so easily can bring. A delightful young boy that he was, the buzz of life came crashing down to a screeching pause as the beast with his precarious jaws wielded forth its piercing claws down the treacherous precipice that points to no wisdom as to the real cause. A wonderful happy little boy, never in tethers of previous ill health or undue skates of infirmity, a mother's shock and sorrow in this unreal vindictive calamity, as tears withering in defiant stealth draw no waver to the glaring reality. In cautiousness entwined with optimism, the healing human hand lays out the very treatable and promising options. Yet caught in the darkness of thought, the distraught parent sees no hope through destiny's unjust, albeit capricious prism. Why not me? Why my poor child? Her mind all in shreds, seeking no exit from the gloomy realism. Indeed, it's a journey with a torrid beginning, and we know the disease is here to stay. Sores in the mouth and many more further along the way. Blood, pain, motions in multitudes, and other unpleasant ailments that ruffle the day. But Mum, a treatable ailment is what this is. Time-tested treatments do work well to keep the disease at bay. Long and arduous as it may seem to be, a journey through the dunes of despair, as the sandy storms of disease bring on the unexpected flare. But Mum, listen, stay positive. Yes, not my child, but we do deeply care. With the deluge of neo-treatments, when one fails, there's always another effective one, and yet another one within our stare. Thank you. Dear listeners, take care, and thank you for being with us once again. Goodbye.